Please welcome Rahul Dubey.
With me are these four esteemed peers and colleagues of mine. I'll give them a chance to introduce themselves and tell them a little about their organization and kind of their roles there. But really going to be talking about that kind of digital-first approach, digital-first mentality, what that means, what are some myths around that, and what are some really kind of actionable takeaways within this peer group that they can share. Failures and successes are just as equally as important in this kind of transformation over this terrain that we're trying to kind of navigate that no one's been over before. So great way to do this is to learn from each other, keep it interactive. I definitely want to open it up for a question and answer at the next, but really want to take a moment here and let everyone kind of introduce themselves, starting here with Vivek.
Thanks. Good morning, everyone. I'm Vivek Garipalli. I'm the CEO of Clover Health. So Clover is a pretty small-sized Medicare Advantage plan. We're right now just in New Jersey, a little over 30,000 members, and hoping to grow to some new markets later this year. We started the company about 4 years ago, really around the thesis of building our MA organization around a unified technology platform. So we started by building a single source of data truth, essentially, on each of our customers. And then we really take a lot of that information and try to drive out insights and workflow through a lot of A/B testing. And we love MA mainly because of the alignment we have with our customer base in that model.
Good morning, everyone. Karen Babis. I'm a Regional Chief Medical Officer for Molina Healthcare. I'm an internist, geriatrician, hospice, and palliative care doc by training. And trying to bring technology to a Medicaid plan is a challenge. They're kind of stuck in, this is the way we've always done it, this will work, because that's the way we've always done it. But as our speaker said last night, we're in a resource-constrained environment. We've got to make do with less. So the only way to go is with technology. So I'm thrilled to be here.
Good morning. My name is Chet Uma. I'm the CEO for California Aetna Better Health of California, a Medicaid managed care plan. Started our program January 1st, 2018. So brand new plan, trying to grow membership. Of course, in California, as most of you probably know, if you're from California, it's a delegated model. There's challenges in getting data and technology implemented to have an effective program. And if you know about Aetna, most of our services are through shared services. Again, if we have to move the needle on the technology side, we have to work with our corporate, and it benefits all the other health plans who are part of our Medicaid segment. But glad to be here, and we'll be discussing more about integration, data use, and early adopters, etc.
Good morning. I'm Jim Napoli from Blue Cross Blue Shield of Arizona, Corporate Medical Director. My background is in internal medicine. I've lived in the state of Arizona, great state of Arizona, for 18 years. Blue Cross Blue Shield of Arizona has been operating as a trusted advisor to many in this market for over 77 years. We are heavy in the exchange in the rural counties throughout the state of Arizona, and have commercial lives primarily under our management, as well as all our hosting Blue Card efforts from the other plans across the United States. I work in practice transformation with our providers as well as our provider partnerships. So I have a key role in value-based care through all aspects of the medical ecosystem, not just limited to what we do with doctors, but what we do with hospitals, what we do with specialty pharmacy vendors. Really, the questions are coming from very good questions are coming from our employer groups as to what we're doing for value. So the transparency, the questions, and the digital solutions that are needed to help bring those things forward in a very productive manner are very, very much at the forefront. So I find this to be a very timely opportunity to speak about what we're doing with our health plan. Thank you for having me.
Thanks for joining. You mentioned not only just what was going on within Blue Cross Blue Shield of Arizona, and a couple of the panelists talked about other players in the ecosystem. When we're designing digital, you're looking at some of the providers, you're looking at care management, retail pharmacy. what is their main purpose? So they ask that question of who is it that they're trying to serve. And I know that we discussed a little bit of this in the little time that we had to prep, but really with that in mind, who is it that we're trying to serve? We talked about employers, we talked about PBMs, we talked about kind of distribution channels, and then what is the ultimate goal? What are some of the KPIs and that insightful kind of thoughtful approach to what it is that we're trying to do and looking at that kind of ecosystem. So in the past, it's fair to say that a lot of the things that we've done have designed to serve the institution, whether it's the payer, the provider, medical loss ratio, satisfaction, readmits, those type of things. And the output has been felt by the end user, which is the consumer, which is the patient, and they've kind of felt like that their needs have not been met. I was wondering if there's an element in kind of a digital first design and digital infrastructure as we're mapping this out in transformation, one or two single elements within your organization or your strategy that really stood out as a fundamental truth when designing for that. And I know with Clover, the vision starting off, and I have a co-founder here who can say much better than me, was that kind of digital first from the ground up. And so we'd love to have that kind of perspective there and kind of lessons learned as you were building it out.
Yeah, no, absolutely. I've been in healthcare for a little while, and prior to Clover was on the provider side and on the data side for a little bit as well. And I would say at least most organizations I've interacted with or been around that have been in healthcare for a long time have not really built their business around the customer. It's typically been built around the business model, whether the business model was driving up unit price, utilization, or cost management or whatnot. And if we kind of pull off the lens off of where we move away from healthcare and just look at it from a consumer perspective, the best example I think we have is Amazon versus Walmart, where Walmart was actually always had a really strong technology organization. They're one of the most kind of strongest from a logistics and transportation perspective, but their entire tech stack was built around personalizing the experience for the store. So when you walk into Walmart, Walmart knows how many tissue boxes they're going to sell or how many umbrellas they're going to sell that day in that location, probably within a 1% to 2% error rate, but they don't know what you're going to buy because their entire tech stack was not built around the individual. And so obviously Amazon had a big advantage day one around that. I think there was a misnomer in the early days that Amazon was selling online and Walmart was brick and mortar. In reality, Amazon was building their entire stack around the individual consumer. So when we started to build Clover, while we had a bunch of learnings in the first couple years, for us it was really around building our entire technology stack around a single understanding of each customer. So if someone calls us, we're taking in that information. If they're telling us, the name of their dog down to who their caregivers are, when we think about social determinants, for example, we don't really like using that word. For us, there's clinical data and then there's everything else. And everything else could be signals, but you don't really know until you sort of start doing retrospective analytics and start using basic ML and analytics on it or whatnot. So when we think about digital first is really having that right technology foundation, and you have to give your technology team autonomy to experiment and drive decision making. I think a lot of kind of business-minded organizations, the senior management team typically will tell the technology team what to build or what to do, and that's typically how you lose great technology people, and they run off to a more exciting company.
It's also crucial to give that technology and that software, to trust it, to be patient with it, to allow itself to reveal the certain insights that are there, to take it to serve those customers that you want. We're in an ecosystem, and so we'd love to talk in terms of we're serving multiple people sometimes, right? We're not just serving the consumer and the family member and the employee and the employer, but also providers, care managers, and everyone in kind of the care continuum. I was wondering, Karen, if you could kind of talk a little bit about that, as you kind of mentioned, especially as a chief medical officer, days of decision making at the top of the department by one person are gone, right?
Absolutely. We're doing joint decision making. Yeah. And just adding, yes, we need technology, but we still need high touch in a lot of circumstances. Interestingly, about 78% of our Medicaid population have smartphones. But just because they have a smartphone doesn't mean they know how to download an app or interact with it in a meaningful way. Our Medicare population, the fastest growing group in the U.S., population in the U.S., is the over age 85-year-olds. And guess what the second largest is? Over 100-year-olds. And believe it or not, they're using technology as well. How do we adapt it to their needs? How do we enable communication, which is really key for us to make decisions together, establish goals for our patients, our members, and I think that's very important, is what are their goals and how do we incorporate technology into their goals.
But after establishing what kind of that value is, that value creation or perception of value is for the end user, right? And how it would make an impact their lives rather
Exactly.
than, and that's a very human, emotional conversation because you're talking about certain needs of certain socioeconomic backgrounds and levels that are there too. So you really kind of need to look into those insights. So it isn't the technology first. I think we've looked at that as digital and IT, and health IT is going to be that silver bullet for a decade and a half, 2 decades. And now we're really looking at that business value and how to serve them in a really kind of human way, with technology being that kind of enabler. With the data, we were talking a little bit, Chet, about how data is so crucial. Talk a little bit about not just what's going on with the luxury of having this new plan and the challenges that come with it, but then you're playing with some kind of antiquated legacy systems that exist in California, obviously, that is on top of it. What are the barriers in terms of other people's internally through Aetna, the mothership, right, as well as providers within that new market in terms of their native environment and not being able to, there's a willingness but not being able to share that information?
Well, I'm going to start with the health information exchange. There was a lot of money which was provided to automate, not only the EHRs at the provider offices, but also the exchange of the information. People have heard the word meaningful use, but what is the definition of meaningful use? I think it's so different by provider. Providers got funded for the software as well as the implementation, but I think the meaningful use has been very different by provider, by also the companies, vendors who have been implementing it. So as long as they met the minimum requirements, they got funded. But did it serve the purpose of getting all the data aggregated? So if, say, that happened, I think, and if all the providers, hospitals, and physicians, PCPs, specialists could share the data, I think that would have been a great thing, because real-time data would really be beneficial for better outcomes for the members. At the same time, if you look at the technology which is available in the non-clinical side, non-medical side, like Facebook or FaceTime, there are things being posted real time and the whole world knows about it. If we could do something similar with our healthcare data, where all the providers are connected and they're submitting data to a centralized repository, and then it's disseminated to all the stakeholders who are part of the members' care, I think that is something which we should strive for. There are challenges for that. I think it's communicating the data back and forth. There's also the it's not HIPAA compliant, or it may be because the systems, one system cannot talk to another system. I think not only throughout the entire healthcare delivery system we have this issue, but within an organization, if you look at a health plan, for example, the software the people use is sometimes so bolted on, and it's not fully integrated, so the member services people cannot actually see those notes and cannot provide real-time direction and care to the members. So these are some of the challenges we face today.
Major challenges. There's empathy to have on the provider side as well. They're using an EMR, which is essentially a coding efficiency software, right, to manage care and clinical and create innovative care pathways and change cognitive bias around kind of the delivery of care, and doing so in the dark, really kind of on a system that's conveyor belts, that's based on volume in terms of reimbursement. I want to just a quick show of hands here. How many people would agree with the fact that we have a higher chance of adherence and consumer engagement with the stronger provider affinity that we create in the marketplace? Great. It's taken me 2 years of talking about this behind closed doors at the lab to really relinquish that kind of control in that direction that plans want to do, but they realize how many patients does a plan actually see in a year? 0, right? Unless we actually are able to have a purview digitally, we're not going to be able to see that, and unless we create the infrastructure and enable providers to do this. So James talking about this, one of the things that has come up over the last 3.5 years of stated needs from a health plan coming to the lab to solve a problem has been, we need to build provider affinity, and we need to actually do something about physician burnout, because it's absolutely, really, there's a direct line between the morale, the resiliency tools available or not available, and reimbursements versus care that's there. Or is that something you had mentioned on provider kind of relations? Is that something you're talking to about your kind of high-performing, valued network, which should be the majority of your physicians?
I mean, absolutely. Everybody in this room who has gone and seen their doctor understands that things are being rushed, that, you know, sometimes we have signs where people will go in and say, you could only ask 2 questions today, because it's such a transactional mentality that is going on. And frankly, we're in an era where that should not be happening anymore. Everything should be based on outcomes. Everything should be based on value. And so part of our everyday job is to work with these practices and help them understand about making a transition from fee-for-service that we're in today to fee-for-value, so they could work smarter, not work harder, so they could have the time and the ability to spend with the patients and develop that trust, because fundamentally care is delivered at the level of the patient and doctor interaction. And so whatever we can do to enhance that is certainly going to engage both the member and it's going to engage the provider. And without those 2 components, we're not going to get the better clinical outcomes that we need to squeeze all the excess out of the system. So we fundamentally work with these practices in a manner which we send our teams out so they understand these practices, and we have kind of a practice transformation formula, if you will, where we're working with these practices, looking at what their EMRs are, looking at what their systems are, looking at what their workflows are. And we're giving them kind of best practice education, if you will, saying, well, you know, we've seen other practices that do this, and this is how they solve that problem. So we're really trying to make the practices throughout the state of Arizona very efficient in what they do, because at the end of the day, the biggest complaint we get about value-based care is the administrative costs and the administrative work of having to do this. And so really, what we're finding is if we just help them transform their practices with improved workflows, we provide the actionable real-time data that they need, so when they go in and see the patients, they have all that information there, and they could spend the time that they need to develop the trust and relationships with these patients, that ultimately it is going to help us fulfill our population health goals, which is going to be better patient experience, better clinical outcomes, and at the end of the day, it's going to bring value to the system, and it's going to bring affordability to the system. And we absolutely have to have those components for healthcare to be sustainable moving forward.
A critical component of what James said here, and a lot there. One, to really actually have that focus is that a stakeholder does matter, and that part of our role and the jobs to be done and problems to be solved as a payer moving forward in an organization of health and well-being is to be that aggregator of information, to be able to shoot that out at a time of need at the point of care. Very, very crucial to be able to do that. And then to give that power to the other stakeholders, which is the provider and the consumer, to really kind of get onto that adherence through digital channels is great. The key component that I see here is that it isn't a financial incentive. It's an administrative burden, reducing that. And so a lot of the things that we realized that were mythbusters was just keep giving them financial incentives. You can introduce all these programs and have them engaged. They don't have the time. Right? And so one of the mantras that we put up at the lab when we're talking about it is keep independent docs independent. And that's by really being the new era of kind of an MSO in terms of chronic care coordination, care continuum, transitions, and things like that. It's Bravo. How important not only is the digital infrastructure there and the clinical care pathways, but really kind of aligning and really saying in that situation of data share, we'll go with Vivek here, is it to arm the provider just as important, if not more, in terms of the care continuum and their care teams than it is for the consumer and family members at this stage of value-based care?
Yeah, no, and just because we're focused on Medicare, it's obviously different population than the commercial side. And so we've taken a two-pronged approach. And being in New Jersey, I don't know how much time folks have spent in New Jersey, practices are highly fragmented in that state. There's a few what we call large practices, not necessarily integrated, but it's kind of the opposite of South Florida or whatnot. And so what we have done is really kind of identify the patient population that we view as kind of the most complex. And we've moved that patient population out of their actual practices and taken over their care in a home-based primary care program. So similar to a Landmark, for example, on care management, but where we take over primary care and we're adding acute care services in the home in the third quarter, for example. But on the physician side, physicians don't generally just willingly give up patients. And so we've been thinking about, what is the best way to kind of get into their workflow for a few years now. And we've kind of given up on, or have given up on the idea of trying to push information effectively through the EHR. Pulling it out is much easier than pushing it back in. And the EHR market is so fragmented, and they're all fighting for market share versus trying to actually innovate. And that's kind of the situation that they're in. So we've taken a different kind of approach that we hope will be successful. We're not sure if it'll work or not, but we've went to all of our primary care physicians that represent the bulk of our membership, and we've actually just doubled their payment. And we said in return for doubling our payment to you as the primary care physician, we want cooperation to take your complex patients, move it into our primary care program, which reduces their office visits in that Clover population by about 20%. And then we've developed our own tool to give them at the point of care that connects to our data warehouse. So they have everything on this customer down to, if this patient was upset in their waiting room the last time they visited, and they can talk to them about that or something that they shared with us. And obviously gaps in care, diagnosis capture, and anything else that's personalized. So what we've really done is value that incremental time that the physician is going to spend with the patient, overpay for that, but in return they're using our software. And just being very upfront, saying we're just not going to integrate with this thing over here, and get alignment that way. And really just view ourselves as a technology partner with the physician. So we'll know more in a year as to how that worked out.
I have to come back and report back on that utilization, but I think driving that isn't a matter of cutting any sort of care or any access, right? And it's still a focus on quality where, yes, we want them to engage, point of entry being primary, knowing that as many touch points as they can get with the primary, that it's going to lead to adherence, which is going to lead to lower costs, we're hoping, and that's what you're going to report in a year, right? So we're, looking at that, you've engaged another stakeholder. We've talked about trying to even facilitate internally. That's important. Is there an example, and I'll open this up to the panel and then Q&A, but is there an example where you have ran into a brick wall with the 5 or 6 important entities within the kind of value consumption chain of care for a patient? So retail pharmacy, PBMs, I know I've run into that in terms of outcomes-based risk-shared agreements between payer, provider, and pharma, and everyone on board except for the PBM. And so there's that kind of one person that's in the way. Has that delayed things, and then how were you able to overcome it, or it's still a work in progress? And so, we'll start with you, Karen. Go ahead.
I'll kick it off. I think one of the most challenging areas is behavioral health. And I think it's very critical, you mentioned pharmacy, to bring in that adherence lifetime so that when the person leaves the hospital, they're leaving with the medication, they take the medication that they're supposed to take. Unfortunately, behavioral health hospitals across the country are not connected. They have not undergone a digital transformation. 15% of the standalone BH hospitals have EHRs. That's tragic. And I find their lack of integration with medical to be a serious issue. And so how do you get them to come to the table and realize, if you're profoundly depressed, you end up stopping your insulin and end up in the hospital for that reason.
The comorbidity aspect of that
Right,
is very, very
right.
high. So it's almost like it's an imperative to be able, an action trigger to be able to screen for behavioral health, mild, moderate to severe, just to get them activated. A lot of new enrollees coming in off the exchange every 12 months. We don't have a purview into their health status or definitive risk. One of the things that we're working on with home diagnostics that my fellow Allison, I don't know if she's here, there she is, have been working on in terms of getting that activation at home diagnostics in a cost-effective way to get that definitive risk to layer on top of the predictive. And for behavioral health, that's the action trigger to get them into those things to kind of complement
And we
that.
can use remote patient monitoring for behavioral health, but we have to have the buy-in of the psychiatrists and the BH leaders first.
A lot of challenges there, and aligning what those kind of the intrinsic motivation, financial motivation, impact it's going to have, that's going to be there. And then you also have kind of policy-wise, I think there's 22 states where you can't treat behavioral health and medical in the same facility, which needs to be overhauled completely. It's hard enough to kind of reach that audience, and now that you have them and can really impact their lives and kind of public health in general. I mean, articles are out now, suicide rates are up 25% in the last 20 years. What is going on, right? It's not just opioids. So other aspects, how can we use some of these initiatives that are going on, Chad? I keep coming back to you on data. We talk about data-driven insights, all of those things. How can we use things both internally to facilitate the business case, and then when we see those barriers, that is in a world that for 3 decades has been adversarial across different kind of silos, to kind of help build that case?
Sure. So as we think about whole person care, so it's not only just the clinical side of the person's care. All health plans, all payers probably have most of the clinical data on a person. But you're right, Karen, there's a wall between behavioral health data and clinical data, the physical health data. So I think it's very important that somehow we coordinate both sides of data so that a person can get total care, not only on the physical side, but also on the mental health side. In addition to that, I think what we should also be looking at is the non-clinical data, such as the social data, homelessness, food programs. I think, once you integrate all of those data together, when a member goes to see a provider, the provider probably thinks, okay, this condition is related to or is attributed to a person being homeless because, one, they don't have a shelter, they don't have food, it's causing this issue. So I think integrating all those data together in some way would produce better outcomes for the members, as well as, it'll build efficiency in our delivery system.
In terms of, James, in terms of the provider, efficiency, absolutely, right? Information, not just terms of last visits and where they went and got their prescriptions filled. Are we looking at truly integrating systems in terms of scheduling appointments, allowing care managers, those other risk-bearing entities that are sharing risk with us to be able to kind of help drive the continuum? We've talked about kind of the procurement process around certain programs that are known, clinical weight loss, all of those things, and then we don't allow those experts and that solution provider that has proven it out and quantified it to do their job, right? And so how do we actually, we want to arm the physician because we believe the affinity with the patient is going to be best, but sometimes we don't want them to communicate directly with them about formulary or coverage or steerage. Is that moving away from that a little bit more and allowing the digital to do the digital and arm the physician to do their job?
Well, I mean, so to answer the question, you have to look at what we are doing overall with our medical management programs. And yes, care coordination is essential to bringing, the right services at the right level of care for those particular patients. And so we need to be able to look at technology and digital that fits into our programs and helps us obtain our goals of getting the patients to the right places for the right types of care. So a lot of that still works with our overall care coordinators, our care managers, and this just doesn't belong in a primary care doctor's office. This is everywhere. So when our members are in the hospital, our highest risk members go to the hospitals, we have to have interactions with the care managers in the hospital, and we have to help not only make sure that these patients are being navigated, but that we employ the right types of technology to help us do that. But I think the key point to understand here is that role is going to continue to grow. Technology will continue to help that, but the technology has to have a solution for what we're doing with our medical management programs. It just can't be technology that's out there looking for a problem to solve. It has to solve and integrate and fit in with what our clinical care pathways are. And if it doesn't, it's not going to be something that we're really interested in.
Yeah, it's something that there's a lot of noise that's in the marketplace. I understand the funding mechanisms of VCs and PE firms, very important for innovation and kind of helping for the transformation. But also at the same time, there's a distinction between an industry and a market. An industry's wanting to actually kind of prove that out, right? And so there's, what do we go with? How do we make this move forward? What's going to be the most effective? And do we focus on that innovation and that transformation, the multiple innovations rolled into one on a clinical level, care path level, or is that too sophisticated at this point when we focus on the consumer as an end user and just allowing them to book an appointment or to just easily look up coverage information and kind of programs that are there? So before we open up to question and answer, so are we looking at front or back end type or clinical, and what's more important from your organizations?
Yeah, I think there's certain components if we think about ease of use of a plan, whether it's appointment booking, being able to have accurate statements and information that's not confusing. It's highly correlated to care coordination, but I think in a way that is more consumer intuitive, but not business intuitive. If a customer doesn't trust your organization, they're not going to engage with you when you talk to them about medication adherence, or you're outreaching them to want to go visit them in their home. And that's really kind of how we view it, which is, there's a lot of what I would call micro opportunities within a health plan where it costs a decent amount of capital to actually implement. It's a lot of annoying workflow. It's hard to initially rally people in the organization around, why is it really important to have forms that are easy to understand, or different languages. Why is it important to spend that extra 20 minutes on the phone with a customer? But if you do that, and I think this is more for Medicare than totally understand the commercial side, you just have a bulk of people who don't care about healthcare until they care about it. But once you're 65 or disabled, you care about healthcare a lot more. So if you can build that trust through all these little things that I think consumers have gotten used to in other industries, your probability of efficacy on things that maybe we care about from a cost perspective start becoming a higher probability of success.
Can I mention one more stakeholder? Yes, we have the providers. Yes, we have our members, our patients. If you have a state Medicaid plan, you also have the state. And the states are generally not very advanced always, and we may want to do something digitally with our membership, which would be better, faster, cheaper, more effective. But the state is stuck with, no, you need care managers doing this, and they have to do this in person or whatever, and you have to attack 5% of the population. So our other big stakeholder, at least for the Medicaid plans, is the state regulations and bringing them along.
And pulling that around of who's going to be able to influence that a little bit more. And I think that actually builds a cause of major challenge and roadblock. But what other state organizations and entities? Is it Secretary of State? If it's social services, is it something else that has some political clout within the council, within Department of Health, that can actually be able to rein that in and say, okay, let's, through really insightful and effective and accurate risk stratification, let's pick this population, right, and say 4,000. Because I promise you, if we can manage 4,000 with technology, we can get to 400,000. It's a matter of getting that framework down first, which is very kind of analog at the beginning, especially dealing with the state. So it's finding that aspect of it, of who's the player, who's the state serving. Okay, ideally taxpayers, not always great. It's the kind of the coffers and those, the powers of bees and the influencers and things like that. So getting them kind of on board of what's going to be there is part of the key. So we're really not just limiting it to the traditional stakeholders. There's new entrants, but then there's also other players that we can tap into, such as social services. We've seen it in care coordination that has been digitally enabled to be able to look at public safety and public health organizations, fire and police, that are idle assets that are sitting there being able to do home visits within the integrated into the plan and integrated into the care continuum, not being separate. So one of the things we talk about in digital is to really be able to spot where the opportunities are, the new entrants that fill gaps where we know where we want to be in 2 or 3 years, to partner with them prior to them becoming competition. And they're solution providers, not vendors, so they should be looked at as any kind of key member in the stakeholder ecosystem, such as providers, because they're going to do things that payers and providers can't do, definitely consumers can't do. So great insight. We have about 15 minutes. I'd love to open this up for Q&A if you have kind of the creative juices going, and if you don't, we can take a 2-minute coffee break so you can get some. Be pretty good to go. So. Show of hands. Go ahead.
One thing this brings to mind to me is historically as payers, insurance companies, we have a little bit of a short-term perspective. You may have a member for a year, you have a 2-year contract, and some of these interventions and preventive measures, you're not going to see results for many years. And some of the investments that you're talking about, take a great deal of time to build that relationship. Just curious as to the panel's sort of thoughts about beginning to shift to an approach that does look at the whole life spectrum of somebody, that we were to have a member 10 years,
I love that. I look at my health over the duration of my lifetime to date, and health plans, we look at it for someone's health over a 12-month period and then reset it January 1. So interesting in terms, it's not necessarily looking at health, it's looking at risk. But yeah, very, very good question in terms of that. James?
Yeah, I mean, I'll take that question. I think it's a great point. And so one of the things we look at is, what is the churn rate of our population? And the key is to get that churn rate down as low as possible, which is what you're alluding to, because if we invest a lot of resources and time and effort in coordinating care, getting the appropriate therapies to this patient, and then they just leave, while that, helps one of our competitors, and maybe that happens more often than it should. So I think the question we need to ask ourselves is, why is that happening? Or why is it happening more in our plan than others? And so that's where fundamentally I think the trust issue that we talk about really comes down to driving that, because if they trusted us, if they thought we brought affordable products to them, if they thought we were really a value, they wouldn't leave. So why are they doing that? And so I think that's where we really need to understand our consumers better. And so a lot of what we're doing is around surveying and kind of creating personas on these members. So we know the best way to communicate with them. We know the best way to try to engage them get into our portals, giving them the kinds of information that they need. But ultimately, we want to not only manage these members with these chronic conditions well, but we want to keep them to see the benefits of everything we're doing. But if we don't know them, we don't bring them differentiated and affordable products to the market, then we are not going to keep them. And so we really need to make sure that we're doing everything we can to build that trust and develop those programs to do exactly that and keep that churn rate as low as possible. It'll never be zero, but I think we could do better than we're doing today.
Without question. I mean, we do spend a lot of time looking at value and defining value inclusive of the institutions, right? It's reimbursements, and it's almost sometimes dictated to us what's value and defined for us. In the consumer's case, it's not. They're the ones, the sole person that can actually have that perceived value of care, and it's very, very different than clinical. It's very, very different than cost. It's a very big myth buster. Because it's healthcare, because it's something that is very complex and sophisticated and that they don't have an understanding of, they're okay with paying a high premium for it if they're going to get something in return. That's where the disconnect is, and I'm sure the personas and journey mapping you've done have seen that. If you see that layered on top of a provider journey map of what they go through as well, it gives you even more insight to be able to kind of give that digital aspect of it. But it's the only way that if we're going to treat, we've done a couple speaking sessions, and this past one at HIMSS was around what are components to keep people well, because if we keep them well, we're going to keep them around. And that's the mentality of looking at them as not good risk, bad risk, churn, but actually managing them so that it is maintaining and impacting their lifestyle seamlessly. And because it's healthcare, and unfortunately the care continuum and the care experience has not been pleasant for most people engaging in it. It's been very conveyor belt, trial by an error. very small things go a very long way to improve that perceived value for the individual, and it's very important to kind of do that. And I think if we can focus on that, picking up the phone within 1 or 2 minutes, saying that and actually delivering on it rather than being on hold, it'll go a very long way to keep them around and diminish that churn, and it's a start.
To your question, so from the perspective of Medi-Cal health plan, those are challenges we face every day because our Medi-Cal members have a choice. For example, in San Diego, I'm one of the 7 plans. So if they don't like Aetna Better Health of California, they can move to another plan. I think the key here is if the providers, and these providers are participating in all the health plans, if they have information on the member through my plan or any other plan, I think the outcome could be better, regardless of members jumping from one plan to other. But this is where I think the coordination of the information, the health data would be very important so that the provider, regardless of which plan they are part of, regardless of the member, which plan they choose, Aetna or Molina, whoever it may be, the provider is still looking at the same data on the member. I think that probably would be build efficiency and produce better outcomes.
And just to add to that, the providers can be our best advocates to retain the member. If they like us because we've paid claims timely, we give them lots of data, we help them with their operational efficiencies, maybe they will view us more positively, and in turn they'll say, hey, stick with this insurance plan, it's a good one.
Absolutely. I mean, especially a payer's knowledge of reimbursements from CMS and understanding what's there and programs that they're going through. One thing that comes to mind is the CCM, chronic care management reimbursement, for being able to manage a patient's health electronically outside the 4 walls of a doctor's office. An independent doc office isn't going to be able to, one, have the knowledge, skill set, or the time to be able to build out a digital infrastructure for care management. And most sophisticated provider networks don't have the time nor the capital to be able to do that, but we can because it actually impacts our margins and our kind of overall medical spend, which is a top priority for a lot of the payers, is to decrease medical spend without having an impact on the quality aspects and improving that a little bit more, which is going to come through that relationship and innovation. Any questions on, go ahead.
Yeah, this is Deb. Hi, Deb Hoskins, plan in Massachusetts. So as I was just hearing Karen's comment, it made me think about, we need to think about the regulators in this conversation, because with Massachusetts and the 1115 waiver, certainly in Medicaid, redesigning the way that members are assigned to plans. So in Massachusetts, basically IDNs and networks and their associated physicians needed to choose a partner, a payer partner, to become part of an ACO. And those PCPs can only have members in that payer-partner relationship. So that, is helpful to the Medicaid and, to the regulators in terms of the issue with churn. And they want, Medicaid wants members to be more long-term with their providers, with their payers, because of the outcome. So, thinking about trying to partner and advocate with regulators. I mean, prior to this year, every month, a Medicaid member could just switch plans every month.
And that was our experience in Illinois
Right,
as well,
right,
and we
so-
lobbied against that. and
Exactly, so how
now
can-
they
how-
can change during the first 3 months, but then they're stuck with us for the rest of the year.
Special enrollment period?
So,
is that what
yeah,
you're talking- in
so now they're
California's
locked in for at least a year, but to Jim's point, once you get them locked in and now you're developing these relationships with the providers, hopefully you can work towards sustaining that membership over a longer time.
It's difficult in the Medicaid population, people coming in and out throughout a 12-month period, right? And so, yes, we want them to move above and beyond, be empowered to get off Medicaid, but then also we want them to be in Medicaid for a long period of time. It's kind of a double-edged sword to be able to do that. There are independent ways. It definitely has to be state kind of sponsored or funded openness to it and to those ideas that is more operational and effective and having an impact on the delivery system rather than optics, news cycles. Saving $1 billion is great, but in comparison to how much we really could save is not so great. And so that's the real thing is are we going into playing a game of politics or policy? And that's something that the conversations because you can get sucked into a political conversation very quickly that really sucks up a lot of the resources that are out there, the time and the energy that's there. More importantly, the end result is that it didn't get done, which means that for a lot of people in this transformation period, it means it can't get done, which is the worst direction we can go into, because it could be. It just means it can't be done with those people, with those tools, with that model. Other questions?
Hi, David Jacobson, Arkansas Blue Cross. My question would be, maybe for each of the panelists, kind of your wish list or one priority item. There's so much in digital and technology that we can all do, various areas. If there would be one area that you'd want to prioritize, there's multiple areas that all need to be done, but if you had to prioritize the one most impactful choice of where you'd invest or focus the investment, the deployment, the application, what would that be?
For me, it's in the behavioral health area. And we're actively seeking to put pharmacies and behavioral health telemedicine at clinics, figuring out how to do it in FQHCs and other locations so that we can have a more integrated, seamless model and have it all in one place.
I think for us, again, in the Medicare population, is just it's having full accountability over the truly at-risk population, including really low data latency around them.
Jim?
I have so many, I don't know really where to start, but if I had to pick one, I think it would be in population health management. You know, we really want to be able to set up the appropriate types of reimbursements and attribution of population into those providers, and all the practices are going to be different. The way we interact with one system may not be the way we interact with another system. Some people can take risk, others don't have any idea what risk is. Some are just going to be shared savings upside. Some are going to be pay for performance. Some are going to work on MLR calculations. So really being able to attribute, figure out that population, get the right kind of software in there to be able to help us calculate that and be reliable, I think is very important, because payment integrity is not just about fraud, waste, and abuse. Payment integrity is making sure that if I have a value-based program, that I'm paying that doctor the right amount of money, or vice versa, because we're partners. I don't want to short them, and I don't want to be shorted. So that kind of solution, I think, is paramount to my everyday job.
For me, I think it will be, like Karen said, integration of the behavioral health data and the social determinants data. So, so that the providers can have the total picture of where a member is, as not only on the clinical side, physical health, behavioral health, but also the social data, homelessness, food programs, etc. So that
Lifestyle impact.
Yeah. And again, the focus would be whole person care. So that would be my highest priority.
I think one of the things we've been able to prove out at the lab too is take something that was a very B2B, enterprise to enterprise type of approach to utilization, fraud, waste, and abuse. And with a very fast-growing number of consumers becoming that initial risk-bearing entity, carrying that financial burden of high-deductible health plans. And a lot of our health plan members, when I was at AHIP in the lab, was part of that. And now, as it's a commercial entity, working with the plans to say, you know, you're not really looking at the small dollar amount fraud, waste, and abuse because it's not cost effective to do so. So you're letting $500 or $1,000 kind of slide. That's a significant amount of money for a family. It's a significant amount of money for an individual, and especially when they're that risk-bearing entity, whether it's $1,500 or $5,000 before $1 of the plan kicks in. And so we've created a tool that was once enterprise to enterprise and B2B to send a communication out to say, hey, listen, you paid out of your HSA. We realized that last month's visit had a little discrepancy. We paid the whole thing except for this line, and we put $148 back into your HSA. And to corral all the key stakeholders to do that and communicate without the payer, without the individual knowing we were doing it, without them signing up for something, paying for the service, is that perceived value, is that we gave them $148 and someone was watching their back. That's the one where I would love to see that go through serving so many different stakeholders that are there, including the provider and getting their money faster. So I'd like to see a lot more of those digital approaches. Time for one more? Hi. That was the least selected plan, right, on their website. I hope.
People don't even notice the names, honestly, the names that plans pick for their plans that they push to the public are horrific. That is one small thing everyone here could do that would help. But, you know, this notion of redesigning high deductible, because in the individual market, we're not going to have first dollar coverage, but you want to promote care. And so are these designs something you all in your plans are looking at?
So we're going back into Marketplace in some of our plans. And even though it's commercial, but it's not a high deductible plan or anything like that, we exactly are looking at standardizing, looking at why people didn't like it in the past. And it is for things like not paying for behavioral health, having a deductible for BH as an example. So yes, I think that is an important point, and I think we all need to do it in the plans that we can.
Well, being a Medicaid plan in California, we can differentiate, so the plan is the plan.
A great testing ground for that is the employer market, right? A lot more room, less regulation, value-based insurance design that are out there. Let's use that data-driven insight rather than assumptions. I live in DC, and I always love the people that are designing Medicaid plans. I've never been on Medicaid, right? And no fault of their own, and don't wish that on most people in DC. Some I do, but it's also the same thing of what are the buying habits and lifestyles. So 2/3 of the 60% of the United States goes and shops at Walmart at least once a month. I haven't been to a Walmart in 5 years, right? And we're talking about behavioral health there. So it's really how are we bringing that in, and it's so much more than voice of the customer. It's understanding DC. It's understanding the gentrification. The at point of care has changed. We wanted it in their backyards. Now they're taking 3 buses to get there. You know, all of these things that are out there. And so it's really, really important. The thing is that defining and aligning what that framework is going to be for a viable approach, innovation, multiple innovations to deliver and have multiple applicability across the stakeholders is going to be key. And it's only going to come through digital channels. That doesn't have to be incremental to value-based. It can be simultaneously. It can enable value-based. We have 4 peers and colleagues here that can prove that out, and would love to talk to you more about that after. And I hope we have a wonderful day. And thanks again for giving us your time this morning. Appreciate it.